I'm really delighted to be here, and I'm aiming to share a few ideas from implementation science that you might be able to take away and apply to the kinds of work that you're trying to do in all sorts of different ways to improve services, to improve how people get access to services. So off we go. Right. So I'm going to sort of talk about how can we approach the task of getting good ideas into practice. And Alex was talking more about evidence into policy. I would say my focus is quite different in some ways because it's about evidence into practice and actual service delivery. However, interestingly, there's some connections, I think, and hopefully you'll see as we go along. Right, okay. So what's the point of all this? Implementation. Why do we need to understand it better? Well, we could have lots of evidence that certain initiatives, therapies, interventions are successful and have a positive impact on outcomes, but sometimes they're simply not implementable in the settings where they need to be implemented so that they can have those impacts in the longer term. We do a lot of clinical and health research, and often the best evidence is the randomized controlled trial, for example. They're often conducted in quite artificial conditions. Lots of things are controlled in terms of the patients that come into these studies, the protocols around those processes. And at the end of them, they might tell us, well, is this particular intervention effective or not? If it's effective, that's great. If it's not, well, was it because the actual thing we were trying to do doesn't have the impact on health outcomes that we hope for? Or is it that it just wasn't implemented properly? And sometimes we don't know that. Increasingly, we build in process evaluation studies, and I've done a lot of these in my time, and so I'm a huge advocate for really good embedded qualitative research, and I think that's the only way you really get to an understanding of impact. But sometimes even that really isn't enough. So in order to move things forward in implementation science, we're really trying to understand this problem of implementation much better, developing tools, theories, ways of thinking so that we can embed those alongside the clinical and applied health research that we're doing to try to get improvements in services and outcomes. So there's lots of reasons why understanding this better is important. Okay, a few definitions. Implementation research. Interestingly, I've always used a definition from the journal website for BMC Implementation Science, which is the journal for the field. They've recently changed what they say on their website, and they're steering away, I think, from pinning it down too much, but I still think it's useful. The key point here is it's about the scientific study of methods. So some of it is about understanding the problem of implementation, but much of it is about improving the theories, the methods, and I think really making them much more accessible for people that don't necessarily do theory or have a chance to get their heads around the details of theories. I think they should be much more practical. And it's about understanding the influences on implementation across all the different levels of problems that we're looking at. And Alex was talking about policy. And some of this work can be applied in different ways to problems about evidence and policy, whereas others might be about the endpoint delivery of something new. Okay, implementation. There's lots of terms. I'm going to acknowledge that in a minute and then move on quickly because we don't want to get hung up about terminology. But the thing I'm mostly talking about today is implementation. So I just want to present that as something that's actually strategic. It's a set of activities that are planned generally and executed to make a change. And that can go on for quite some time. It's not a one-off. Often it involves lots of different things at once. So it can be quite complex and complicated, and it can go on for quite a long time. But the important point is it's not something that just happens. It's planned and it's strategic. Okay, quick acknowledgement. You may have heard of some of these terms before: implementation science, improvement science, knowledge exchange, knowledge mobilization. which term is right for you and the problem you're using may depend slightly on where you're coming from. But they have a lot in common, which is that they're about kind of putting knowledge into practice, and they're about translating that in ways to get an impact, which is what we're here for today to talk about. And if anybody's really fascinated by this, and some people are, there's a link on there for a paper that's worth a look. Okay. And the slides will be available, I'm sure, afterwards. And I'm aware some of the detail might not be seen from the back. Do put your hand up at the end if I've missed anything important. Okay, so we have lots of theories and frameworks. And the question is, well, where do you start? How do you know which one to use? Most of what I'm going to talk about today is kind of some tips and a guide for navigating that literature and being able to find what's most useful for you. So this is from a paper by Per Nielsen, who's at the University of Linköping. I hate having to say that because I know I get it wrong. And they're doing some really great work on implementation science up there in Sweden. And he categorized these different approaches to try to put it into a simpler language. We've got models and theories that describe what's happening in an implementation process. Some of it is about understanding and explaining what happens and why it happens that way. Some of it is about evaluating implementations. Okay. So, but what I would say is that theories aren't always everything. And although that's kind of what I'm going to talk about most, don't forget that atheoretical approaches are also important and valid and based on instinct. And often the people that really know what has to happen and what needs to change are those that are really embedded in the work that's going on. So don't ever disregard that. Use your instinct and perhaps look at some of these approaches and see what they can add on to that. So they might be process models that give you step-by-step kind of processes, how to do this implementation work. There could be, a lot of them are frameworks, and these are lists of, say, factors that affect implementation that have come from synthesizing all of the evidence, all of the literature that's out there. And they serve as a bit of a checklist sometimes, and you can use that to do interviews or systematic reviews or whatever. There are also theories which kind of try to go a little bit further to explain how a process happens and why, and to understand it a bit better. And normalization process theory, which I'll talk about a bit, sits in here. And some of them are very much more focused around evaluation. And if you're doing a study where you're implementing something, but you really want to kind of prove whether it was effective or not, those approaches are more useful there. Okay, as if it isn't already complicated, you might be wanting to do any of these things. You might be planning and developing new interventions. So, you know, you're designing a new service. You're kind of planning where that service is going to be, who's going to be involved, what they're going to be doing, what training they need, etc., etc. Or you might be evaluating interventions. And I would say much of the implementation science literature is all around this evaluating. Not all of it. Hopefully things are moving more towards the applied end, but a lot of it is currently there, I'll be honest. Or you might be using these approaches to roll out proven interventions, and that's really around something that you already know works, and these approaches can help you think about, well, actually, what have I got to do to actually spread this out in practice or to different services? Okay, and then you've got all the different levels. So some of them might be more structural, and they might be about policy, others sort of at different levels of the organization, or provider levels, or even individual behaviors. Now, clearly, you're going to need a different, if you want to use a theory or something to guide and focus your efforts, you maybe need to think about matching it up in that respect. So individuals would be, say, practitioners, families. It might be a behavior change. Let's get this consultant to deliver this brief intervention for alcohol. Provider service level, it could be teams of providers working together, getting them all doing the same thing, delivering a protocol for therapy or whatever that is. And then there are other, I think they get increasingly more difficult the more diffuse you get in terms of organizational level factors and structural level factors, but some of the theories really are designed to tackle those issues, so they're important. Okay, so I'm going to talk in a bit more detail with some examples about one of the theoretical approaches that is out there and being used. It's the one that I've co-developed with colleagues, but I'm not the only one that's using it. So we've seen lots of people using it over the years, and we've learned a lot about how those other people have used it in different ways. So I'm just going to give you a couple of examples that are hopefully a bit relevant to the kind of work you're doing around drug and alcohol research. Okay, and so these have been around for a while, 2007, 2009. So we're kind of evolving our own theory and our approach as we go along. So this is often my challenge, to be very succinct and describe what is normalization process theory. And forgive me if I just from now on just say MPT, okay? That's what I mean if I say MPT, because it's a mouthful. It is a theory that explains how implementation happens, with a focus on how what we're doing when we're implementing becomes a normal practice, part of what people just do every day, almost to the point that they don't really need to think about it that much. It stops being disruptive, I guess. I would say at its most basic level, MPT is a way of thinking about the problem. So it frames your thinking. It doesn't tell you what the answers are, but it helps you ask the right kinds of questions. And it's important to think about how different groups of people need to work together to achieve it. There are lots of theories out there. Some of them are focused very much on individual behavior change, for example. What we're interested in is the idea that much of what we're doing when we're changing practice or changing services is we're looking at work that people do together. People are rarely responsible for making a change on their own. They have to work together, and sometimes you're changing the way that people work together. And we feel that really needs to be an important reference point. So we start with the question, well, what is the work that needs to be done here? I'll illustrate the four constructs a bit as we go through the next few slides, but there are four basic things. Coherence means it needs to make sense to the people that are involved in it. In much the same, in that could be the actual intervention they're delivering, or it could be the policy you're trying to get them to engage with. There needs to be participation and engagement, and they need to be committed to that. They need to be really properly signed up to it. There needs to be action. Something needs to happen, but it's often at the point where people are actually dealing with this new practice where unanticipated effects come up and they have to troubleshoot. Sometimes they can be resolved and sometimes they can't, so you need to understand what's going on there. And monitoring is really important, because if people are putting in all of this continuous effort to change something, if they have no sense of whether it's actually making any difference, then how are they going to sustain that commitment and make things happen? So if you want to come away and say, well, what's MPT about? I would say just remember this slide. It's all about the work. It's what is it, who does it, how does it get done, and why did it happen like that? And that could almost be your qualitative interview topic guide if you were applying it in that way. And that could be enough. A very unstructured one, but sometimes that can be the best approach. So normalization, we mean this as a process that happens over time, and we focus on the work that actors, people are engaged in through these activities so that it can become embedded. Okay, a few empirical examples just to illustrate this. Okay, 5 minutes, right? So the first one, exploring factors affecting implementation of tobacco and substance use interventions in a secondary school setting. This was a systematic review that was done and used normalization process theory, or MPT, as a kind of interrogative framework of the literature and to synthesize that and report it. There were 15 studies in this review. There's not a lot being done actually from an implementation research focus in secondary school settings altogether, and drug-related, alcohol-related interventions as well. So very small literature. Only 5 of those 15 studies were qualitative, but this was a mixed methods review. And you can't see that at all up the back, but if you're interested, you can have a look at the paper. Of course, when you do something like this and you have theoretical constructs, you're looking to see whether these things are issues in a body of literature. what she found was there was a lot of findings around research around the constructs of coherence, whether it makes sense, participation and engagement and action, but nothing is being said about what's being monitored and appraised and fed back to those that are involved in doing the work. And if you're interested in this and look at the detail, there was some nice, unique things. Some things were generic across lots of implementation studies in terms of the factors, but some of them were really to do with school settings, a lot of confusion about whose responsibility. Should it be teachers delivering these interventions, or should it be the professionals that know more about if it's a drug intervention or a smoking or alcohol or whatever? So quite useful for mapping the field. Another one was a qualitative study around implementing brief interventions in alcohol in primary care. And so they used the theory to frame the interview topic guide and their analysis. So I'll just step out here because it's a little, you might not be able to hear me as much. I think the bottom line was it made a lot of sense to the general practitioners, but it really wasn't getting translated and embedded into practice at all. It prompted the GPs to try and have difficult conversations that they didn't necessarily feel were appropriate for them. They had to make judgments about how much drinking was too much drinking, and where it was being used successfully, it was generally delegated over to the practice nurses. So room for improvement there. I won't say much about this paper because we're running out of time. So this was looking at, again, brief alcohol interventions in an endoscopy unit. And they used two approaches, two theoretical approaches to examine this problem. MPT was used to understand the wider factors that were affecting the embedding of these interventions, but because much of it was targeted at changing individual behavior, they also used a theory from psychology, which was theoretical domains framework, and they found that combination really useful. So the point I wanted to make is it's never one theory or another, it might be multiple, and you use what you need. Okay. So in terms of MPT, it's about understanding the ongoing efforts to make sustainable change through building understanding, establishing and maintaining participation, and appraising and adapting the work that's being done as you go along. It's a continual process. Okay, so very briefly to end on this, can theories be practical? Last week, a paper came out which said yes. Although this is what I've been saying for quite a long time, but they've really packaged it for, I would say, a lay audience. They're for practitioners and researchers that are new to the field of implementation science. So if you're interested, do use that as your starting point. So I can't say too much about that at the moment, but there's lots of sort of case studies from personal experience, and they summarize the 10 most, what they consider the 10 most commonly used approaches. MPT was one of them. But I thought that was really useful. From our own work, it's all about translating the ideas into practical tools that people can use. So we've got a toolkit on the website where you can use a sliding bar to make assessments in relation to different questions. The first one there is, say, participants distinguish the intervention from current ways of working. Do they or not? Maybe some do, maybe some don't. The point of these are not the ratings you make, but the thinking that you do in having that discussion, and you might have that discussion in teams. Time up. Okay. There's also a survey, and that's on the website, which I won't say anything more about. There's some papers there. And the thing to say is, although there's lots of emphasis now on measuring things, and it's back to the idea of evidence, some people are a bit skeptical that qualitative findings, are they really evidence or are they anecdotes? I would say yes, it's really important, but others want measures. Let me just say, though, implementation science is recognizing that measures in the traditional sense, in terms of psychometrically valid, et cetera, important, but not just the important thing, because they need to be user-focused, user-friendly, and you need to use them in practice. I'm not going to talk about the implemental study. I'll save that for another time. But we're doing some work to package all of this into a much more comprehensive process to guide implementers through, in this context, upscaling and implementing electronic health interventions across Europe and Australia. And our key ingredient, we think, is forcing the implementers to do cycles of user engagement, stakeholder engagement, and troubleshoot through different processes to really target and tailor their implementation processes. Okay, so this is the last one. There's plenty of theories and tools, but you need to choose what's relevant for you, depending on what you're trying to achieve, the kind of change you're making, and be challenged. The easy thing to do is just use them to evaluate something. Try and see how you can use them to actually design and use them prospectively to actually plan your implementation strategies, because that is breaking new ground and it's starting to happen, but only just. So thank you very much, everybody, for listening.
Northumberland was my name. I'm the team lead for Harms in the network. And it was just to relate what you were saying back to what Alex was saying earlier about power and inequality. And one of the, I suppose, when I'm thinking about implementation science, is about how do we accommodate within that issues around power and inequality. And I wonder if you have any.
Yeah. Well, I think it's all about stakeholder engagement and participation, and really understanding who's affected when you're changing something and making sure you get that representation, because you will find out things you weren't expecting. I think it's tricky. There's a lot of new groundbreaking work, though, sort of within applied health research around co-production methodologies, and I'm fortunate to be involved in a couple of studies that are using those approaches or trying them out. One of them is trying to use co-production approaches with young offenders around mental health, but actually she found it very challenging and couldn't access the very people whose situation she wants to end up improving, because of complicated situations around accessing participants and gatekeepers and etc. So I think I would say that's the starting point, is making sure that you ask all the right people, and then that will kind of get you or keep you on the right track, I think.
Thank you, Tracy. Thank you for that. And just to let you know, we are using MPT in certainly one study I'm aware of at the moment, and a couple in the planning. We're going to use MPT, and we're thinking about using it alongside other theoretical frameworks. So I just was interested in how often you're aware that if it's used alongside other frameworks, and what those might be. So I can sense whether if our plan is going to work.
Okay. And so I'm giving a blind answer because I don't know exactly what you're doing, but quite often, so what you've got to think about in any sort of, if it's a study, there's two things going on. There's the actual, if it's a therapeutic intervention, so you're changing something there, and if that's behaviorally focused, then clearly sort of things like the theoretical domains framework, health behavior change wheel might be useful for that. MPT is more about how it all comes together, though, or kind of organizationally, but it's where the people that are delivering and doing the work sort of kind of reach down to the service users and other people, and also out to the team and the organization. So MPT tends to look at the factors affecting the implementation. Other theories might be helpful more so for designing the interventions so that they will target the outcomes so it depends what your intervention is. But another kind of more, I'm also seeing MPT combined with co-production, evidence-based co-design methodology, which is really interesting and exciting. And I think there's a really good synergy between those two. And also realist evaluation methodology is another one, which is what works for whom, when, in what circumstances. And you can probably, if you're familiar with that at all, you can see how that would resonate really with the things that I've been talking about. So quite often they can come together quite well. So I don't know if any of the approaches you're thinking about come from those, but they're just examples.
You did cover some.
And we can discuss that after. Yeah.
Is there one last question then before we go on to the presentations? Anybody else got a burning desire to ask just now, or shall we pick it up again later on in the day?
I'll be around all day.
You'll be around all day, excellent. Yeah. Fantastic. Okay, Well, if we could just put our hands together and thank Tracy for that wonderful presentation.